Okay, perfect. So I'll get started. I hope everyone can hear me and see me.
No, I'll click on start webinar. Good to go. Bye.
We started.
Okay, perfect.
Everybody please mute now, okay? 3, 2, 1.
Let's go.
Yeah, folks. I hope I'm audible. And
Recording in progress.
Okay, perfect. So, hi folks, my name is Sahaj. I'm leading the GTM and strategy efforts for all of Sarvam's model APIs. And today we are going to be diving a little bit deep into one of the use cases that Sarvam has been working on, right? Along with one of our key partners, that is HealthPlix. Again, before we dive deep into it, I just want to take a moment to thank each and every one of you who has taken the time out to join us and to learn more about what we are working on and to understand more about our products. I cannot reiterate how important your support and all the love from the community has been over the last few months. And we really hope that this webinar inspires you to build a few more very cool ideas that can make a big difference to our daily lives. So having said that, I'll dive right into the main topic for today. So since for quite a few months now, Sarvam has been working with HealthPlix to build within the healthcare space, right? Of course, I think all of us understand the kind of impact and the kind of importance that this industry has on our daily lives. I don't think I need to go too deep there, but it's been one of the focus areas that we wanted to solve for, particularly voice in the healthcare space. And who better to do it with than HealthPlix, right? The largest AI-powered health tech platform in India today. And I'm very proud and honored to present that Chaitanya Raju, the Executive Director and Chief Product Officer of HealthPlix, is here with me today to talk a little bit deeper about what they have built. So without wasting too much time, I'll hand it right over to Chaitanya to take us forward to what they've built. Over to you, Chaitanya.
Sure. Thanks, Sahaj. I did see a message that there is some echo. Do let me know if there's echo from my side as well. Sahaj, you can go to the first slide. Yeah. So firstly, thanks for inviting me to this webinar. I'm happy to be doing this, happy to be talking about our experience with Sarvam APIs. You know, as the founder of a company, I'm also very keen to work with other Indian firms in the AI space to solve for very Indian specific problems and challenges with AI deployment, right? So that's where I think Sarvam is going to play a huge role, and I'm happy to be partnering with them and sort of talking about them in today's event. So before that, let's sort of introduce HealthPlix to you folks, right? So HealthPlix, largest AI-powered health tech software company in the country. And I want to talk, start by talking a little bit about our journey and sort of how we came about, right? HealthPlix, if you sort of look at a country level, the sort of challenges in the healthcare ecosystem, you'll see that underdiagnosis and misdiagnosis is a big challenge, right? So what does that mean? A patient goes to a doctor, he consults with him, but oftentimes doctor may not have enough information about the history of the patient, potential allergic reactions, anything else that sort of contextualizes that patient's particular situation. And with that context missing, oftentimes doctors don't catch things early or may sort of misdiagnose as well, right? Patients struggle to explain symptoms, so on and so forth, right? So we have these challenges in Indian healthcare. And our belief is that the way to solve for this is by clinical documentation, making sure we're able to keep medical records of the conversation between doctors and patients, lab values, test values, all of this, if it is available to the doctor seamlessly at the point of care, you can solve for a massive sort of healthcare challenge in the Indian ecosystem, right? Just to give you some metrics that, sort of third-party studies have done, about 50% of the time in the Indian healthcare ecosystem, diagnosis is either missing or, is incorrect, right? I mean, that's a large number if you sort of think about it. And oftentimes, our data shows that a problem, a chronic disease progression, so somebody with diabetes getting a kidney problem, this sort of disease progression is detected anywhere between 18 to 24 months late by doctors, mostly because the history of the patient is not always captured, right? So it is super critical to capture the doctor-patient conversation, capture as much information about the patient as possible in the medical records. So then that can be used to contextualize the treatment that the doctor is giving, right? So that's the sort of the story of why HealthPlix came about. And today we are at 14,000 plus doctors across the country, hundreds of hospitals who use the software, and we do 1.5 lakh prescriptions a day, right? So we're talking about a pretty significant scale in the Indian ecosystem, around 60 million patients who have had at least one prescription written on our platform, about 120 million prescriptions written on the platform, right? So it's a significant scale that we have gotten to. But if you think about the Indian population, there's still a long way to go, right? And that's where our journey has been to sort of keep digitizing more and more doctors and patients to be on a digital platform so that then the care that the doctor can provide to the patient can improve over a period of time. Next slide, Serge. So as we went about this journey, we have been at it, pre-LLMs, right? Before the later advancements in AI, we've been using AI and digitalization to help our doctors and patients over a long period of time, right? So I've gotten to a good scale with that, but the advent of these new models, Gen AI models, and firms like Sarvam coming in, it helps us sort of go to the next, sort of take the next big leap in digitization, right? Why? Because if you're able to simply listen to a patient-doctor conversation and write a prescription for the doctor, write a detailed prescription for the doctor that captures diagnosis, complaints, advice, precautions, sort of dosage information about the medication, how should the medication be taken before lunch, after lunch, empty stomach. This is all very, very very, very useful information for the patient. And the more of that you capture, the better health outcomes that the patient is likely to get, right? So, but doing this obviously take time for the doctor, and that's where voice comes in, right? If I can simply listen to the patient-doctor conversation and generate a prescription, a rich prescription for the patient, the doctor's job is done, right? The doctor doesn't have to spend an extra 5-10 minutes writing down a prescription and can focus that time on looking at the patient, right? So that's where voice to prescription, our Halo product was sort of researched and developed over a long period of time, and have been launched recently and has had very good initial traction in the market because it sort of solves for the problem of documentation without the doctor having to spend the time, right? So, and this is the time factor is very important here because if you think about the Indian healthcare, oftentimes you go see a doctor, the good doctors get a lot of the patients, right? So if you're a sort of a well-reputed doctor, well-renowned doctor in the community, you will often see anywhere between 40 to 60 patients a day. So if you can save 5 minutes per patient, that means you're able to do a lot, you're able to see a lot more patients, right? So the patient load is asymmetrically biased towards the better doctors in the country. And that's where, if you can solve for time, you go a long way in making sure that the documentation actually happens. And ultimately the patient health outcomes improves at a population level. Yeah. So now coming to this problem of voice to prescription conversion, right? What are the challenges here? If you think about an Indian OPD situation, that we've all been there, we've all seen doctors. Oftentimes, doctors are in sort of very noisy rooms. There's a lot of background noise, people talking in the background. The doors are often kept open, so anybody passing by, the noise gets through. Language is obviously a big challenge. You can see that doctors have to treat patients oftentimes in multiple languages. So in a metro like Bangalore, doctor could be meeting Tamil patients, Telugu, Kannada, Hindi. right? And you have a lot of workers coming from all over the country now. So the doctor has to deal with having to treat patients who don't often speak Hindi, English, and the standard language or the regional language of that city, right? So language, just the same doctor being able to talk to various patients is part of the problem. The other problem, of course, is that we, as Indians, love to switch languages when we talk. We never ever speak a single language, especially in a little bit more informal context. When you're trying to explain the symptoms, automatically your native language comes up, right? You're trying to explain something to a doctor about where something hurts or where there's something burns and so on and so forth, right? So when you sort of have those kind of conversations, you typically want to speak your language that you're most comfortable with, right? So this sort of language switching happens a lot in the OPD, and that's obviously hard for a model to sort of work with, right? The other challenge is if you take sort of the general global models, they are not very good with the Indian context, right? So they will not know basic brand names like Dolo, for example, right? It's not something that an OpenAI model would know to deal with because they're not trained heavily on the Indian brands or Indian data necessarily, right? So once you start to have the local context on the medical context in the conversation, the transcription becomes super hard, right? And a lot of the global models fail there, and I'll talk about how Sarvam and HealthPlix have solved for that, right? So these are some of the challenges with doing voice to text in an OPD in a sort of Indian context, right? It is very different from, say, how things work perhaps in the US, right? Where it's a closed room, you're speaking one language, maybe perhaps two in some cases, maybe you speak Spanish. There's no background noise. And so it's very different from sort of how the Indian context works. That's where we felt that the solution has to come from sort of from players who are solving for the Indian context, right? And all the problems I spoke about. So that's where when we started working, while we tested all models, we found Sarvam to be a good partner there, and I'll talk a little bit more about that later. Next slide. So given this, right, so sort of the mission that we were on in terms of digitizing doctors' practice and helping improve health outcomes, as we sort of were venturing in that direction, and we saw the advent of GenAI models making a big leap in the voice-to-text transcription and sort of capabilities getting better, we were able to launch something called as Halo, which is the HealthPlix AI-powered clinical documentation product, right? What this means is whether you want to dictate, whether the doctor wants to dictate to the platform or to simply just turn the mic on and have a conversation with the patient, the prescription is automatically generated. It happens within 10 seconds for most standard conversations, which is super important. And of course, accuracy is important as well, right? So as you think about doctor relying on software for prescription generation, especially in the healthcare context, getting everything right is important, right? If your dosage is not right, you're taking medications 3 times a day instead of 2, it's a big impact on health, right? So it is super important that every nuance of the prescription is accurate. And that's where we had to do a lot of work to make sure that the accuracy is upwards of 98, 99%. So where most of the time the software just works, and the doctor has to do a quick scan, a quick review, and send out the prescription, right? And that's, you have to solve for it to that extent where accuracy is that high and the speed is that good for the doctor to be able to adopt it in a Indian OPD context, right? So that's the product we have launched, been live for a few months now, and I'll talk a little bit about sort of how we went about solving the problem. But Sej, maybe you can play the video now and just show them how this works, and then we can go behind the scenes and understand how we went about building it.
Absolutely. Let's get it.
Started.
Good afternoon, doctor.
Is it okay if I record this conversation?
Yeah, sure.
How have you been lately since our last visit?
Doctor, I have been okay. I have been experiencing frequent migraines lately. हफ्ते में 3-4 बार होता है.
I'm sorry to hear about it. And were there any lifestyle changes recently since your last visit?
I have been under a lot of stress because of work, which is affecting my sleep cycle and my diet too.
Side lifestyle changes can be the contributing factors. So let's review your medications. Are you still on naproxen?
Yes, I am taking naproxen 500 or twice a day.
Is there any other medication other than naproxen?
Yes, I'm taking Imitrex 50 जैसे ही headache शुरू होता है.
So let's review your lab reports. Your vitamin D3 level seems to be quite low. It is 50 nanogram per ml. This can be the contributing factors for migraine attacks.
Okay.
So we need to start the tablet Apprize D3, 60,000 international units once a week.
Okay, that sounds great. I'll start taking Apprize.
So there can be some non-specific causes which can increase your migraine attacks. So we need to manage these triggering factors and your stress levels.
So doctor, how can I manage my migraines better?
So what we need to do is we are increasing the naproxen dosage to 1000 mg twice a day.
Okay.
Along with that, you can take Imitrex 50 mg whenever you have headache.
Okay.
You need to manage a headache diary. So where you can note down your triggering factors whenever you have headaches. So you need to have a healthy lifestyle. Like you have to eat on time. You have to have 7 to 8 hours of sleep. Maintain a sleep hygiene.
Yes.
And avoid stress.
Okay, I'll start taking that. And when should I come for next follow-up session, doctor?
You can visit me after 1 month.
Done. I'll see you in 1 month. Thank you so much, doctor.
Thanks, Edge. So, that's video is sort of meant to give you sort of overall feel of how this software works in the real world. Having said that, typical OPD rooms are a lot noisier with multiple contexts, language switches and so on, although they did switch between English and Hindi, right? But this is sort of meant to sort of give you a feel of how the software works, right? Now, if you sort of look at what the prescription generator looks like, it has a lot of information. It has information about previous history, current medication, the advice given by the doctor. So all this is super important. It's not typical that, when you go to a doctor, not always you get this information in the prescription, and especially it's not digitized, right? Our belief is that you need to get this level of detail in the prescription, and it needs to be digitized in a structured fashion, so that you can then carry this prescription to the next doctor you see, or when you come back to this doctor, and there's so much context about your health in the prescription, right? That can be taken forward. And that's when, once you have that information and all that information is presented to the doctor in a simple manner, is how doctor will have the capacity to find things early, spot problems, look at disease progression, new diseases coming up, so on and so forth, right? So getting a rich prescription is very, very important for the doctor and the patient. And that's why, we want to, through Halo, not just get like the basic information about medication and so on, but get the details, because that is critical for improving health outcomes. Now, how do we go about it, right? So if you see that we have multiple challenges here. One is, of course, getting the text, right? The voice to text piece, that's important. And the second is the language, the text to actual prescription is also not straightforward, right? I'll give an example of how that that could vary, right? So when you say ghabrahat as a Hindi word in a regular language, you're thinking, okay, you're scared of something, right? But ghabrahat for a heart patient could mean palpitations, right? It could mean high heart rate. It could mean different things depending on what your chronic problem is, right? Similarly, if you say sir fat raha hai, you're saying your head is not literally exploding, right? It is you have a severe headache, right? Let's say you have weakness. Now, weakness for a diabetic patient could mean that the diabetes medication that is given to the patient is too strong, and that's causing like a low sugar in the body, and that's causing weakness for you, right? So once you have your health history, the same word in text can mean different things for complaints and diagnosis, right? So adding that medical context to the text is very important, and that's something that we have been doing for the last 10 years, building out these capabilities where we are able to understand what the doctor types and sort of what that means for a patient in terms of complaints, diagnosis, and so on, right? So the way we did it is we sort of split the problem into two. Instead of trying to solve for everything in one step, we said, let Sarvam handle the voice to text, right? Let's make sure that we get the best models out there to do the transcription for us. We'll get the transcription done. And then from that transcription, we'll use our intelligence, we'll use a AI layer on top of it to use all the data we have with 60 million patients, 120 million records, where the text can be contextualized with that information to do a better job at writing the prescription accurately for the patient, right? Because if you think about it, if I just simply write weakness as weakness, it doesn't really help the doctor, because doctor has to go and type in hypoglycemia, which is the actual complaint, right? He has to type it, so you're not really solving for his problem of a quick prescription, right? It's only when you're able to contextualize that text into the medical language that needs to go into prescription is when you're adding the value, right? So that's where HealthPlix does the job. With Sarvam, obviously it was super easy for us to deploy at scale, because if we needed to build ASR for 9 languages, it's a whole other R&D problem, right? Which Sarvam is solving for us. Imagine us having to sort of do that plus this. Would be a much more complex problem. So the way we did it is let Sarvam handle the ASR piece, and we'll handle the medical contextualization of it. And that's sort of how the two players collaborated to get this done, right? What was very exciting for us is we started off with a couple of languages, and we were able to quickly scale to 9 languages because Sarvam simply gave us models for 9 languages, right? So our sort of contextualization remained the same. We sort of switched the model for when we have the language switches, right? And you have to understand this is super important for deployment, because if I'm deploying Halo to a doctor in Bangalore, I can't just say Hindi, English, and Kannada, go for it. He may see a Tamil patient, he may see a Telugu patient, and I have to have it work in all languages before I can make it useful for him for all his patients, right? So that speed of deployment was only possible because we had a player like Sarvam help us out. Now, the second layer of contextualization, of course, requires a lot of work as well. We have multiple models that run the contextualization piece of it using the data that we have. And then we have like a council that decides how to combine the output of these multiple models. Incorporate in that information about the Indian brands. So let's say a Dolo versus thousands and thousands of diabetes brands that are out in the market in India. So doctor, when he says a certain brand, it's important that the same brand shows up in the prescription, right? So that bringing in the brand information of an Indian doctor prescribing to a patient, all of those steps happen as a second layer to then give the prescription to the patient, right? So all of this happening accurately and happening within 10 seconds is critical for it to be useful for a doctor in the OPD setting in India. Yeah. So now we can talk about why Sarvam. I've touched upon this a little bit already. If you think about it, having a company that is building models specializing in ASR is important for us, so that we can benefit from their R&D into various languages, and then use that as a first step to get the transcription for us, the text for us, that we can then use to contextualize and build the prescription, right? If you think about it, if we were to do it in one, right, and we did try it in that direction, we did experiment in that direction. If you were to build it in one step, what would happen, right? I would take a Hindi model and I would try to fine tune it to solve for Hindi prescriptions, right? And now a quarter later or 6 months later, a new model comes up, a better Hindi model comes out. Then what do I do, right? So I have to fine tune it again. So it's not a scalable process to sort of try to solve for it together. It makes so much more sense to you benefit from the R&D that Sarvam is doing, and then simply focus on the medical contextualization, which is what we are specialist in, right? Latency is again a big factor. I like the fact that Sarvam has the streaming approach to ASR, which means as the doctor is speaking, the patient is speaking, the text shows up. It's not like a batch processing where I have to wait for the entire conversation to be done. That is a big benefit for the doctor, because once the doctor sees the text in the in front of him, he feels more confident that the prescription is actually being done, right? So that's important as well. And finally, compliance and security, right? Like it's, as you can imagine, probably even more than financial data, healthcare data has to be secure. Having patient data, being lost, nobody likes to share their health information with others. This is super important for HealthPlix. If you see, say HealthPlix is big on compliance with the best global standards as far as healthcare data is concerned, and we needed a partner who also takes it that seriously, right? That data sent to Sarvam models is not sort of automatically dumped somewhere and forgotten about, and these sort of things, right? It's super important. And we found a partner who understood that and worked with us to make sure that at all costs patient data is safely managed. In terms of numbers, right? We talked about how accuracy is super important. 97% plus accuracy is the level of expectation that doctors have, and we've been able to deliver that. Because once they see a almost ready prescription, all they got to do is do a quick review. Wherever we are not 100% sure of the text, we highlight it in yellow and give the doctor options. The doctor can simply click on it, select the right choice, and then move forward, which means the doctor doesn't have to spend maybe more than an additional 10-15 seconds to do a quick review, make any changes if at all necessary, and then send the prescription to the patient, right? So that's important. Accuracy helps, accuracy of conversion, and then doing it within 10 seconds is super important, because that's how you're going to save the 5 minutes for the doctor, right? Otherwise, the doctor will have to spend that 5 minutes typing out a full page of the prescription. We have done more than 50,000 consultations across the country. Across all specialties, we're able to do this, and which is with something that we are very encouraged about. Doctors are seeing value in this, and we've also seen that typically doctors who are very, very keen to take serious notes, certain specialties who are very, very big on taking notes, patient history, allergic reaction, where all of this becomes more important, they're seeing immense benefit of Halo, right? And of course, real-time working of this is super important. Looking ahead, I can talk a little bit about what we want to do with Halo, but Sesh, do you want to maybe talk about Sarvam first?
Absolutely. So I think, Chaitanya, you already touched upon a lot of the important aspects, right, in terms of having the language support, in terms of the latency. Of course, these consultations will also be in kind of noisy environments, right, where people are speaking over each other. So from our perspective, from Sarvam's perspective, in terms of improving the ASR, these are like three broad themes, right? Firstly, with the V3 model, we will be supporting 22 languages. So we are expanding the range of languages that we cater to, 22 Indic languages. So we hope to cover a lot more of the overall Indian population as well. So that is the very first next step that we want our models to really do well at. Latency, we will be in fact introducing faster models. We'll have interim streaming capabilities, interim transcripts will be given out. Those are a few things that we are right now working on. We also touched upon it in our previous webinar as well. So we really hope that that is something that will ultimately make this product also that much faster, right, in terms of the kind of latency it's able to deliver. And lastly, for the noisy audios, for people, doctors and patients may be speaking over each other a little bit of the time, speaker diarization becomes extremely important. Right? We want to be able to understand what is said by the doctor, what is said by the patient. We want to have those analyzed accordingly. We hope that that will ultimately help the quality of the final report that much more. So those are three broad themes that we have in our mind and that we will be working towards in terms of improving the ASR model. But Chaitanya, back over to you for the overall roadmap for Halo.
Sure. I'll talk about the application side of this, sort of how we're thinking about it. OPD is a big part of our user base, and so we have solved for it and will continue to improve it. But beyond that, the way we think about it is within the healthcare ecosystem, wherever voice and sort of general text input makes sense, right? Sometimes people like to both speak and type, right? Like how we do in ChatGPT, for example, right? So wherever that sort of interaction with software makes sense, we plan to deploy this. So this means front desks in hospitals, junior doctors who take history notes and so on and so forth. It could be other stakeholders within, it could be patients, right? So we thought of thinking about using this, across the board. So wherever it makes sense for a quick capture of relevant medical information for the user, it's in the place that we are, in the place that we want to start deploying Halo, right? I think it can be useful for more than doctors, and that includes other, stakeholders in hospitals as well, right? So that's sort of how we are looking to roll out. But doctor we are primarily and we have a lot of digitizing India's practice. So that will be our focus. As we get into sort of more nuanced specialties, we'll continue to improve our medical models to better contextualize patient's history and so on and so forth. So this means that, for example, if we get into something like cancer, the models need to be adapted to be able to understand the treatment protocols of cancer and then, accordingly transcribe and so on and so forth, right? So adding more and more complex specialties and solving for the medical models needed to handle those conversations will be another direction for us.
Got it. Perfect. So I think that brings us to the end of the presentation, but we still have one section for Q&As remaining, right? So we will be taking a bunch of questions for which you guys have posted in the chat, as well as a few others that we got even to the webinar. So I'll just dive straight into the questions. So Chaitanya, the first interesting question which I think we've seen is one which is trying to touch upon what the journey looks like, right, in terms of driving adoption. I think that's a question that a lot of people were building within not only healthcare, but in general within the AI space, right? That, hey, you have an application, you want people to use it, you want people to adopt it, and you want it to bring that impact that you have envisioned for it. So what was that journey like for you, right? Taking it to the first doctor, how did they perceive it? How did they respond to it? And how did you finally get into the stage it is at today?
Sure. See, when you think about adoption, and this is perhaps broadly true for all AI applications, out there, right? Uh, it is very important to understand the problems first rather than leading with technology, right? So, and this is what I would advise for folks who are building AI applications is to first understand the problem that your customer is facing, and if you're addressing the problem with your AI capabilities, then there will be reception because you are actually addressing a challenge in the customer. You're not force feeding somebody AI technology because something you can happen, right? I think that's the important piece. In our doctor's context, right? Getting the accuracy right is super important, and then convincing the doctor that the accuracy is good is important as well, right? Uh, Imagine how much of trust he's placing in us by using software to write prescriptions, right? So it's a big, it's a high responsibility. So getting accuracy right, and then also convincing them about the accuracy of the model is important, and of course, finally, the speed, doing it fast enough, and doing it in a way that doctor doesn't have to look sort of squeamish or foolish in front of the patient is also very, very important, right? So these are some of the workflow things that we need to solve for. And when we reached out to doctors, it came down to these things, right? If initially when we did like an earlier version of the model and went live with it, gave it to doctors, the moment if the accuracy, suddenly you start making mistakes, some random medication shows up, the model hallucinates, right? It'll doctor will lose trust, and he's not going to try it out again because a wrong medication can mean severe consequences for the patient, right? So getting that piece right, and that's where we did, sort of evolved and did the iterated and did the multi-model approach where there's a council of models looking at the transcription, right, and validating and so on and so forth. So that's the iteration we did so losing trust of a doctor happens very quickly. So you've got to make sure that you're ready when you approach the doctor, and then it just has to work. And the other thing is just fallbacks, right? Something very basic. If a doctor has a full conversation and then model doesn't come back with a response, if the model fails, what are notes about the conversation, right? So it's a big loss. So these sort of things were initial sort of hiccups that we faced. But as we saw the product work well in the OPD context, then they see value, they see the benefits that we've been talking about, and the adoption got better, right? So going live quickly, but then also reacting to how doctors respond to the product was important for us.
Got it. That's super insightful. I think one other question that is coming up in different forms is how important was it to have the Indic languages, right? And what kind of geographies have you seen adopt Halo the most as of today?
Sure. Arnab, do you want to take that question?
Yeah. So we have, the in-person usage, right, is been all over the India, right? It's not just one region, and not just one language itself. There are so many languages supporting, as we said, right? We have almost around 11 languages, 2 being Hindi and English, but apart from that, there are a lot of Indic languages. So we see adoption from various different places, different languages, and not just tier 1, actually, it's tier 2, tier 3 as well. Because with the help of Sarvam and with the help of what we have, right, we have made sure that it understands not just like super accented languages also, or dialects also, so that it works better. And the whole idea is that there should not be any bias towards any language or any region, right? So we wanted to make sure that the coverage is good, and that's what we did, right? We made sure that it is given all across.
Understood. Got it.
So largely, just to add to that, if you see adoption of newer products, we've seen that in the West and South is where our traction, our history at least, traction has been good, and then North and East subsequently, right? So that's we have seen broadly adoption being better in those regions. Yeah.
Understood. And in terms of benchmarking the performance of Halo, right? Of course, there will be aspects of benchmarking the speech to text performance, but in general, how do you go about that evaluation before, you finally took it to the doctors? What were the evaluation metrics you focused on the most?
So, yeah. So there are two pieces to it, right? One is the ASR piece and one is the AI piece of it separately, right? Which we're doing externally after to get a structured output, right? So for ASR piece, a few of the basic ones are which everyone would know, right? Word array, tag array, things like that. But one of the major thing which we did, which was more medically specific, were two parts of it. One was semantic similarity, so that it understands the context and tells you that it should be there or not. Then there was direction error rate, which we are doing internally because in streaming, what happens is that you need information as fast as possible. So we need to make sure that it is not losing information while the streaming is going on, because usually batch performs well generally, but to make sure the streaming works, we had some metrics involved in that. So the internal direction error rate we can also do. And then third pass was medical error rate. So we have a list of medical terms which we have, right, which we know, okay, these are the things which usually doctors will talk about, whether it's drugs, whether it's brand names, like branded names, right? All those things, and to make sure that those things discuss. So that's the initial ASR piece which we had metrics for. Then it comes to the structured output which we are getting. That we had F1 scores for every different diagnosis, medications, complaints, and whatever it is, right? So we did have Rogue and Blue and everything, which is a general metrics which we wanted to, but we had specific metrics to determine if information is supposed to be present in listed diagnosis, is it getting filled or not? One of the ideology which we ever always had was we didn't want to infer anything based on the context. We wanted to be sticking to what is discussed rather than saying that, oh, we think that this is diabetes or something like that, right? Until unless it's not discussed, we're not going to infer it, because I don't want to do the job of a doctor, right? Doctor knows better of what is needed, right? They also wanted to maintain that faithfulness to the data. So that faithfulness and hallucination rate also played a big role in ensuring that we can give to doctors rather than saying that, okay, we will advise also on behalf of you.
Got it. Very clear. One other question which is also coming up, I think again this has also been being asked in a few different formats, but broadly, I know we touched upon it also during the presentation, but how do you view the security and compliance aspects of it, right? I think again, as you mentioned also during the presentation, it is very sensitive data. So how do you approach the security and compliance aspects, and what do you think is the importance of, having, let's say, the data stored in India or any other aspects of that sort?
Yeah, I'll start and Nabi can add to that. See, security is and data security and data privacy is super important, right? There was also some comments on whether PII is stored or how we handle all of those things, right? It's very important we take it seriously. Again, we've been at it for 10 years now, so it's been a big priority for us. So we follow all the global guidelines and Indian guidelines on data privacy and security, which means nobody will have access to patient data. Doctor data is also PII is encrypted. Doctors can only see their own patients. They cannot see other patients. Patients can handle their own data. All of these sort of rules have been built in for data privacy and so on. And then even our own engineers will not have access to private information, personal information, and so on and so forth. Right? So a very strong set of protocols have been built internally. We are HIPAA compliant. We are compliant by the DISHA guidelines that were not made into law, but are guidelines from the government on who owns the data, what data can be used for, where it has to be stored, so on and so forth, right? So all of these things are very, very important to us, and we've been practicing the best practices for a long time now. See, where it becomes important is moving, if you were to call a global model, moving Indian healthcare data out of the country is a challenge for us, right? So it is not something that we would want to do, and I'm sure our patients and doctors would prefer if we had everything in-house in India, right? And that's where for us, working with Indian firm is super important because we would like to keep all the data here, even if it is for processing, we are sending data elsewhere. It has to be within India, right? So our preference is for it to be here. And while other firms are working on having Indian deployments and so on, working with Indian firm is always a preference in that way, right? Increasingly, while these things are work in progress, increasingly we expect the government to also sort of nudge firms to look at sovereign AI models, to look at sovereign cloud providers, and sort of have an India first approach, which I think we are aligned on, and our preference would be to continue to do that. So that's sort of how we think about it. Annam, anything to add?
No, I mean, you covered most of the things, right? So two more things which we do is for other pieces, right? We make sure that there is text reduction and also in places audio reduction to ensure that PI data is not getting stored anywhere so that you cannot replicate that anywhere else. Audios also get deleted so that those information is not there until his doctor wants it. So we delete those as well. So all those things are in place. Apart from that, and it's something which again we should understand, right? It's not something that we are forcing a doctor to use all the time, or forcing that even a patient is not okay with it, they will use it all the time, right? It's about patient consent and doctor consent, right? We provide a solution which allows them to seek, okay, if patient agrees that they want to record it, they're okay with this, then only they will do the recording. If they want to talk about some confidential data which they don't want to record, they can always pause it and continue after that. They can always dictate at the end if they feel like, right? So they have all the controls which we are providing them so that the patient feels comfortable, the doctor feels comfortable, rather than forcing them, okay, you have to record all the things, right? So that also ensures that the names or any PI information doesn't come in, so that they are also sure of what they were recording.
Very clear, very clear. One other question also, which again, this also I think I'm seeing in a few different formats, but of course, I think there's several steps of engineering that have gone into building the Halo solution, as we spoke about also, right from the ASR to the pointing to the medical context and deriving the specific terminology. Would love to understand, the level of challenges or the level of ease that you experienced while integrating all of these layers together, including, of course, the Sarvam APIs as well.
Annam, go for it.
Okay. So for the ASR piece, I feel with the support of Sarvam team as well, right? That panned out to be very easy in terms of deployment and in terms of scaling, right? We didn't have to worry about whether load balancing and stuff like that, right? Sarvam handled it well for us. And given that we are streaming, we didn't have to worry about, okay, how to pass the data, how to store all those things. So we're taking with Sarvam. So ASR piece became very much easier for us. Post that also, it became easier because the output which we are getting is the structure which we wanted to do post processing and some kind of medical context generation, right? We wanted to understand what medical conversation is happening, what kind of information which you want to fill, whether it's Indian brands or it's medications or diagnosis or complaints, whatever that is, right? So it became easier because the structure which we wanted, we were getting from the server, and then the solutions after that. So what we did was we separated out the whole ASR and piece with the whole medical information, so that irrespective of language it is, our system remains same and we can plug and play whatever system is required. So that made it much more easier and more seamless in terms of how the system works, which is why we were able to achieve under 10 seconds, because we put that R&D to make sure it's faster, accurate, and doing things at real time instead of doing it at the end.
Got it. Two more questions, kind of more focused on the use case as well, right? So there is one question that is focused on, what is the average length of audios that you guys tend to transcribe as of today? And secondly, along with the average length of the audio, was there a specific specialty within the medical domain, which was a little bit harder for us to crack?
Yeah, so typically these conversations, for sort of more regular OPD conversations, they tend to be around 5 minutes of length. Of course, there are exceptions. Some tend to be shorter, some tend to be longer, right? But on average, I would say 5 minutes was the length that we saw. If you sort of get into something like a psychiatry, you'll have longer conversations. So it sort of varies from specialty to specialty, right? The place, I think Arnab and I could have different opinions on where it was hardest, but I think if you sort of, as we are sort of, scaling this out to various users, if you see sort of a very high volume GP-CP kind of a doctor, right? General physicians, consulting physicians who see patients for fever and cough and so on and so forth, right? They tend to be very short interactions. And there, you got to get everything right quickly. And oftentimes not everything is spoken. So based on the doctor's sort of best practices or how the doctor prescribes to solve certain problems, you end up, the model ends up making recommendations, right? So for example, it's very, when he's giving Dolo for fever, he might not sort of give specifics of how he wants the patient to take it, right? He sort of assumes the pharmacist will tell him or whatever else, right? So when these conversations tend to be very, very short, it's super hard to sort of get a rich prescription, which we push ourselves to do, right? So we've actually found that to be a very interesting challenge, because our sort of, the way we looked at it overall is, if the doctor hasn't said anything, you shouldn't try to sort of fill in the gaps, right? Because that's a risky thing to get involved in. But the doctor does, in some places he would want you to do that, right? So that's where it gets a little tricky. And it was very interesting for us to sort of look at that.
Got it. Very clear. So folks, I know there's a lot more questions. I think, with what the folks at HealthPlix has built, I think we could ask them questions through the night.
I saw somebody with an 8-part question. I'm like, I'm so sorry, we can't get to that.
Yeah. And I think we're just on time. So, we will probably make that one the last question for now. We'd probably be very, very happy to take more questions. Please send it to us offline through our respective communications. We'll be sure to pass it over to the HealthPlix team also, and we'll try to answer as many of them as possible in time. Once again, thank you so much everyone for taking the time to join. We hope that you found the session insightful. We hope that you can take away some learnings from here. Hopefully it inspires you to build. Hopefully you can also see HealthPlix Halo in action live once you get the opportunity for it. And thank you so much for joining, and hope to see you in the next webinar as well.
Yeah, thank you everybody. Thanks for your time.
Thank you, everyone.